Great. Thank you very much. I always enjoy being invited, and I certainly I'm looking forward to today. So what I'm going to do is I'm going to be discussing where things have moved to in relapsed refractory diffuse large B-cell lymphoma. I know that sometimes these slides can be overwhelming because I am going to show you some actual data slides that were presented by some of the authors as information has emerged, but I'm going to focus on what I think are the most important points and really trying to get through the concept that things are really changing, that we've had development of novel therapies that are opening up new options. And I think it's a very exciting time right now. We've seen change like we have never seen before, probably in the history of DLBCL in the last 3 to 4 years. So these are my disclosures. I do consulting for various companies, but everything I say today is going to be based on my opinion. So we know that relapsed refractory DLBCL can be acute infusing area because there are more options now. And what I'm going to do is talk a little bit about a brief overview of relapsed refractory aggressive B-cell lymphoma or DLBCL. I'm going to review select data, mainly highlighting some of the novel therapies that have been recently approved or are currently in development, but really focusing on the treatments that are currently in clinic or may soon come into the clinic. So we know that beyond what I'm talking about today, there are many, many new things in development, but I'm going to focus on what really is going to be either currently available or imminently available. So to remind everybody, diffuse large B-cell lymphoma is the most commonly rapidly growing non-Hodgkin lymphoma that we treat. So this is a very common problem that usually from the very beginning, treatment is based on a combination of chemotherapy and the monoclonal antibody rituximab. And with that, it can often be cured in many patients, but we know that there's still room for improvement. So before we kind of go on and talk about novel therapies, I did want to talk about sort of what our standard approach is for treatment. And of course, that is based on chemotherapy. Sometimes people don't, the chemotherapy is not a treatment. It's a group of drugs that have been designed to hurt cancer cells. But most chemotherapies are generally not what we call targeted. They have a very broad-based effect on many cells in our body, and they're really designed to damage the DNA in our cells so that cells can't grow and divide. So based on how most chemotherapy drugs work, it's not targeted, as I said, and the goal is to try and interrupt DNA from replicating itself, because that's how cells make more of themselves. So it's got a very broad-based mechanism. And because of the broad-based mechanism, the side effects can also be quite broad, because we know that many cells in our body can also be affected by how chemotherapy works. So the standard chemotherapy that continues to be used right now for the first-line treatment of diffuse large B-cell lymphoma is CHOP chemotherapy, which usually gets given every 3 weeks for 4 to 6 cycles, depending on whether or not patients are limited or advanced stage. A major development in treatment of DLBCL is when we added the monoclonal antibody rituximab. So rituximab was probably one of the initial forms of immune therapy that we had available, in that it is an antibody designed to tack on to diffuse large B-cell lymphoma or normal B cells, and it kind of harnesses the immune system to come in and works together with the chemotherapy to make the treatment better. So again, it's been about 20 years now that the combination of CHOP plus rituximab has been our frontline standard of care. And with that, we're seeing a lot of success. So this is just a curve of outcomes that we see across a population. In this case, this is population data from British Columbia, where I work. And we know that with CHOP plus rituximab, we can now cure about 70% of people with diffuse large B-cell lymphoma. But as I said, there is room for improvement because we want to make this better. And I know that at this meeting, there's been a lot of talk on how we're going to make first line treatment better. But we're going to focus on today is, what do we do if this first treatment doesn't work? So if the first treatment doesn't work, we realize that there are probably different reasons for this. So we think of diffuse large B-cell lymphoma as one entity, but we know that it's biologically very diverse. And I think that probably, the mechanisms at play in individual people with diffuse large B-cell lymphoma are very different. And the reasons why perhaps CHOP and rituximab didn't do what we wanted to do, and that is to eradicate the lymphoma, may be very different from person to person. So we know that there's differences in the biology of the lymphoma itself in between people. We also know that the immune system may be different between different people, and the what we often call the immune microenvironment can affect how people respond to treatment. And then there are differences between individual people that may change how they metabolize the drugs that we give, may change how their body sees the drugs. So we know that all of this variability may make different reasons why CHOP plus rituximab didn't work. So I think it's exciting to think that in the relapsed refractory setting, because we know that there may have been different mechanisms at play as to why people were resistant to the initial treatment, that the more different options we have in the relapsed refractory setting, the more likely we are to be able to tackle, and have better effects across everybody with relapsed refractory lymphoma. So that's why I think it's extremely exciting that we're having more and more options becoming available. So this is the standard algorithm that we've used for a little while now, with once people do have either progression of their lymphoma after RCHOP or have their lymphoma come back after RCHOP. And importantly, we've often distinguished sort of two scenarios, and sometimes this is referred to as being transplant eligible versus transplant ineligible, or candidate or not a candidate for transplant. And that's because until recently, I would say the main treatment we've had that allows us to potentially cure lymphoma that has grown through or comes back after RCHOP has really relied on autologous stem cell transplant. So in the past, this was the biggest next question about, can somebody go on to a transplant or not? And unfortunately, because transplant is a fairly intensive treatment, we know that it's not suitable for everybody based on age and health status. And so probably only about half of people are considered transplant candidates. If people are considered transplant candidates, usually the next step is to go down a route of what we call salvage chemotherapy. It's a different kind of chemotherapy from RCHOP, but it's aimed at trying to start getting the lymphoma under control and to prove that that lymphoma is still what we call sensitive to chemotherapy, so that it makes sense to move on to the transplant. Unfortunately, along the way, not everybody still has lymphoma that's very sensitive to chemotherapy. So sometimes we need to divert to other options. For people that aren't transplant candidates, generally we would move down to those other options. And in the past, most of those options revolved around other kinds of chemotherapies. But as we'll be talking about now, we have many, many more options available. Just a word on autologous stem cell transplant. So I think it's still a mystery to some people when we talk about transplants. There are different kinds of transplants that can be done, but generally when we talk about transplant in the second line setting for diffuse large B-cell lymphoma, we're talking about an autologous stem cell transplant. So that involves actually taking some of those baby blood cells, what we call stem cells, which can now actually be harvested just from filtering the blood and getting out the nice baby blood cells called stem cells. They get put in literally the freezer and saved on the side. And then the stem cell transplant involves getting higher doses of chemotherapy than we can safely give without removing the stem cell. So it's really a way of pushing up the doses of chemotherapy that generally can't be safely given without the stem cell transplant, because we know that one of the most sensitive cells in our body are the normal white blood cells, red blood cells, and platelets. And if we push the chemotherapy up too high, it causes real damage in those cells, and it's not safe. So this is a way of taking out those baby blood cells, then allowing the body to safely get higher doses of chemotherapy, and then giving the baby blood stem cells back, and they replenish the bone marrow. So really the secret behind the stem cell transplant is the ability to be able to give higher doses of chemotherapy. And although this can be very successful for some people and can actually cure diffuse large B-cell lymphoma in the relapsed refractory setting, we know that not everybody can be cured with a transplant. And one of the biggest predictors of who can do well with transplant sometimes relates to the timing of relapse. So this is a curve that just looks at outcomes, again, in my province of British Columbia, based on when the lymphoma comes back from the time of initial diagnosis. And for those people that have their lymphoma come back more than 2 years after their initial diagnosis, we can see in the red line here that outcomes can be very good, and more than half of people can be cured, or half of people can be cured with a transplant. In people who have their lymphoma come back very early, though, again, that's probably representing more chemotherapy resistant disease. And although the transplant can sometimes be successful, unfortunately, it's not as successful in that setting. And it's probably because, as I said, the transplant relies on higher doses of chemotherapy, and probably the earlier the lymphoma comes back, it's really declaring itself to be more chemotherapy resistant. So it's really exciting to see that we now have another option that can offer a curative potential beyond transplant, particularly for people that have either had their lymphoma come back after a transplant, or people who may not be suitable for an autologous stem cell transplant. So chimeric antigen receptor therapy, or CAR T cell therapy, is a very sophisticated new form of immune therapy. It's often referred to as a cellular therapy. I'm sure that you are actually hearing a lot about this at this meeting. But just to really briefly summarize, a CAR T cell therapy treatment involves taking out some normal T cells. T cells are a really important part of our immune system, and they're the cells in the immune system that help fight off bad cells like cancer cells. And CAR T cell therapy involves taking out some normal T cells, again, from the bloodstream, and then they get altered very sophisticated way in the laboratory, or really processed through the pharmaceutical companies that make them, and designed to actually specifically target something that is on diffuse large B-cell lymphoma and some normal B cells that we have, and that's called CD19. So they're basically normal immune cells taken out of the individual person and then genetically modified to want to seek out a specific target called CD19. So when they get put back into the bloodstream, they create basically a little army of cells looking specifically for the lymphoma, and can harness the immune system to come in and attack that lymphoma. So it's a form of cellular therapy, and that the actual treatment is based on the cells that have been designed to seek out the lymphoma and try and kill the lymphoma. And basically it is a form of immune therapy in that it does also corral the immune system to do its job. So this has been a very exciting therapy that has become available really only in the last 5 years or so, when it was initially tested in people who had had their lymphoma come back after at least 2 lines of prior treatment. We saw that there were 3 products in development that are just shown here in a diagram, but these 3 products all had very good success at trying to eradicate the lymphoma. And what we saw is that for people that had diffuse large B-cell lymphoma that had come back after at least 2 lines of therapy, about 35 to 40% of people treated in these initial trials had their lymphoma go away, and many patients had their lymphoma go away for good. I would say that when the data first came out, we weren't sure whether or not this was going to actually offer a cure, and we needed to have long enough follow-up to prove that people weren't having their lymphoma come back. But at this point, we now have follow-up that goes beyond 5 years in some of these initial trials, and there are many people that are well without their lymphoma. So I think it's really time that we can start using the word curative capacity with CAR T-cell therapy, that it does have the potential to cure some cases of diffuse large B-cell lymphoma. What's also exciting is that since these products have now become clinically available and they're available for use, we have more and more data emerging for what can they accomplish in a real world environment. So we know that they're within a clinical trial. Sometimes at the beginning, they do enroll the healthiest people that, that can maybe have easier ability to take on intensive treatment. And now we've seen in a real world environment, so what can they accomplish in the clinic? And there's more and more data showing that what was shown in those initial trials, where about 35 to 40% of people might actually have their lymphoma go away and achieve a complete remission. We're seeing that across a much broader group of people that are being treated, in their own clinics and outside of clinical trials. So it's been very encouraging to see this data emerging, again, reaffirming the potential value of CAR T-cell therapy in some cases of diffuse large B-cell lymphoma that has come back. But most of this data that we have is really revolved around people that have had at least 2 prior therapies, because this is where CAR T-cell therapy was initially tested and developed and approved for use. But it really does beg the question, if it is such an effective therapy for some people, should we use it sooner? And should we use it perhaps instead of planned salvage therapy and a transplantation for some patients, particularly those that we consider to be of higher risk, like people that have their lymphoma come back sooner after R-CHOP? And this was an important question that was actually asked within 3 very important clinical trials that were designed to see whether or not it would be of value to use a strategy of CAR T-cell therapy instead of the strategy of salvage chemotherapy and stem cell transplant for people with higher risk lymphoma. In this case, the higher risk was based on timing of relapse after frontline treatment. So these 3 trials really looked at people that either had their lymphoma not benefit from R-CHOP or had their lymphoma come back within a year of having received R-CHOP. I'm going to go through some of the data just briefly. Again, I don't want you to get overwhelmed by all of the details on these slides, but the first trial that was presented was called the ZUMA-7 trial, and this looked at the CAR T-cell therapy called Axicell. This was a randomized trial, so it was performed in people with diffuse large B-cell lymphoma and other aggressive B-cell lymphomas that had come back after initial treatment or had grown through initial treatment sort of within 12 months. And half of the people on this study went down the standard route of salvage therapy and transplant, and the other half went straight to CAR T-cell therapy. And what we learned from this trial is that the people who were allocated the CAR T cell therapy right away actually had a higher likelihood of getting into a remission and a higher likelihood of having their lymphoma controlled. So this data has emerged in the last year and is still relatively early, but it was a good example that the strategy of going to CAR T cell therapy rather than transplant for these higher risk people might be beneficial. There were 2 other trials, as I mentioned. The second trial used the CAR T cell therapy that we refer to as liso-cel, and it showed exactly the same thing, that people that were allocated to the CAR T cell therapy in this higher risk group did better in terms of having their lymphoma controlled and without need for additional treatment. The third trial, however, did not show this benefit. This used the CAR T cell therapy that we call Tisa-cel. Now, there were details between these trials that were a little bit different in how they were performed. And in this trial, I would say that the feeling was that some of the design elements in the trial and the delay in administering the CAR T cell therapy that occurred in this trial might have led to the fact that it didn't show a benefit. So I think that based on the weight of the data and the way the trials were designed, and with the 2 trials showing a clear benefit, it was approved by the FDA. Now, this occurred just last April. So for patients with diffuse large B-cell lymphoma who, as I said, are of higher risk, so either didn't benefit from R-CHOP or had their lymphoma come back within 12 months. Now the 2 products that I mentioned, the axi-cel and the liso-cel, are actually approved to be used ahead as the second line strategy, as we say, rather than going to salvage and stem cell transplant. So that really was a huge shift in our practice of what we do after the lymphoma comes back or after frontline therapy. So rather than thinking about everybody for transplant or no transplant, now we actually ask the question, if we're thinking about this being suitable for a transplant, what was the timing since frontline therapy? And if it's been less than a year, then currently, based on the data I showed you, CAR T cell therapy is what is currently recommended for most people. However, if it's been more than a year, we know that the trials that we saw of CAR T cell therapy didn't test that question, and we know that those people can do very well with stem cell transplant. So in that setting, stem cell transplant would still be considered the next option to consider. Now, one of the questions this data left behind was, what if people weren't considered for stem cell transplant to begin with because maybe of higher age or other health problems, it wasn't considered appropriate? What about using CAR T cell therapy after R-CHOP or after a frontline treatment rather than waiting until a third line treatment where it's currently been approved for non-transplant candidates? And also very exciting this year, we actually saw some data emerge. This actually was a study based on liso-cel, which is one of the CAR T cell products available. And it looked at people who would not generally be considered appropriate for transplant. Again, usually that's because of age or other health issues. We know that CAR T cell therapy can be used in that setting. So if people are not suitable for a transplant because of age or health status, CAR T cell therapy may still be considered. And this study asked the question, is it safe and effective to consider CAR T cell therapy in these people who transplant is not being considered as a second line treatment, rather than saving it to third line where, initially it was approved for use. And this trial, which was considered a pilot trial, so it wasn't a very big trial and it was not a comparison trial. Everybody on this trial got the CAR T-cell therapy, but what it did show was safety and benefit. And based on this, actually, the FDA has approved liso-cel in the second-line setting for patients who are not suitable for stem cell transplant, and that is regardless of timing of relapse. So this does open the ability to move CAR T-cell earlier for people who are not being considered for transplant in the second line setting. So again, this has been a big shift. This data has potentially allowed CAR T-cell therapy to be accessible as a second line treatment rather than as a third line treatment where it was initially approved. So this is, again, a big shift in practice based on this data that really has just emerged in the last few months. So let's move on now to talk about some additional exciting treatments that go beyond transplant and CAR T-cell therapy. We know that, again, transplant and CAR T-cell therapy are important components of trying to cure diffuse large B-cell lymphoma that has come back or has not responded to initial therapy. But after transplant or after CAR T-cell therapy, or for people that aren't necessarily going to go to transplant or CAR T-cell therapy if it's not thought to be appropriate or safe, we certainly need other options that go beyond chemotherapy to try and improve outcomes and benefit in this setting. And what I've listed on this table are 4 drugs or treatment approaches, I should say, that have emerged and have been approved all within the last 3 years. So when I say that we've seen probably the greatest change in diffuse large B-cell lymphoma treatment than we've ever seen, it's based on the fact that really we've seen many drug approvals through the FDA in the last 2 to 3 years like we've never seen before. And this is based on excellent development of drugs that are now considered to be targeted toward the lymphomas and what we often refer to as novel therapies. So therapies that go beyond chemotherapy, that have sophisticated ways of working, that rely on different mechanisms based on what we know to be sometimes important in the lymphoma cells. I'm going to be talking about these individually a little bit and the data that was emerged to get them approved by the FDA. So, but what I really want to stress is, again, how really treatment for diffuse large B-cell lymphoma is greatly changing, largely based on our understanding of the biology of diffuse large B-cell lymphoma that has allowed drugs that try and capitalize on that understanding of the biology to emerge. These options, I would again premise that they've never been compared against each other. So we're going to talk about them individually. And whenever we think about, using a particular treatment, in all cases, we're weighing in what do we know about the benefit against the side effects. And right now, we wouldn't be, we're not in a position to say that one is necessarily better than the other. What they are is different and use different ways of working to try and fight off the lymphoma. So the first one I'll talk about is the one that was approved first by the FDA, which is called polatuzumab vedotin. This is what we call an antibody drug conjugate. So we talked about antibody treatment like rituximab, and these are proteins that are designed to seek out markers on cells, but antibody drug conjugates are actually combinations of antibodies together with drugs that are designed to hurt cancer cells. So in this case, it is an antibody targeting a marker that's frequently and almost always present on diffuse large B-cell lymphoma called CD79B. And this antibody has stuck onto it a chemical toxin that is designed to hurt the cell. So it is a kind of targeted therapy in that it is directed at the diffuse large B-cell lymphoma cell. When it sticks on its surface, it actually gets swallowed up into the cell, and the chemical, rather than being released in the bloodstream, gets released right into the cell to hurt the diffuse large B-cell lymphoma cell. So it is a form of toxic chemical therapy, but in this case, targeted to the cell itself, leading to that killing of that cell. So in the trial that led to the approval of polatuzumab vedotin, it was actually combined with chemotherapy that we call bendamustine together with rituximab. So it came out in a combination therapy. And as part of the approval, the study included a comparison arm where it was compared against bendamustine and rituximab all by itself. So in this trial that included people who had diffuse large B-cell lymphoma that had come back after at least one prior treatment, in people who received the polatuzumab combined with the bendamustine and rituximab, there was a much higher rate of having the lymphoma shrink away and achieving a complete remission, and a much higher rate of actually having the lymphoma go away and actually having a higher survival with the polatuzumab. So this was, as you can see from the orange curve, a big breakthrough in terms of improved outcomes with the addition of this novel therapy polatuzumab compared with polatuzumab and bendamustine and rituximab. With all new treatments, we know that in addition to the benefit, we need to think about what are the side effects and the risks of the treatment. And this was sort of the details of that was compiled from the study, but I've listed them here. So the main side effects of this combination therapy were primarily the development of low white blood cells, which was temporary, and a slightly increased risk of infection. The polatuzumab also has some side effect of what we call peripheral neuropathy. It sometimes can cause some tingling and numbness in the fingers and toes primarily, but that generally was mild and was a temporary side effect. So the next treatment that was approved for relapsed refractory diffuse large B-cell lymphoma was a drug called selinexor. This has a very different way of working. It actually targets a protein within the cell itself and blocks what we call the transport system from the nucleus. So the cells in our body are quite complicated as cancer cells, of course, and this drug is designed to block a specific protein that leads to movement of other proteins in the cell, allowing them to build up in the crucial area that we call the nucleus of the cell and harm that cell. The trial that again got this drug approved with the FDA was performed in people with diffuse large B-cell lymphoma who had already had at least 2 to 5 prior treatments. This was a pill drug, so it gets given as a pill twice weekly and was continued until it stopped working. This is a bit of a busy slide, but it basically shows the main results of this, and that is that about 1/3 of patients benefited from this pill, and about 10% of people actually had their lymphoma go into what we call a complete remission. So it was able to control lymphoma for a period of time in about 1/3 of people who received it. Again, all potential drugs have side effects that we need to think about. In this case, I listed some of the main side effects here. Similar to many of the treatments that we use, low platelets was seen with this drug, but not so much in the way of low white blood cells that can be seen sometimes with chemotherapy. But there were some physical symptoms that people experience, like some nausea, tiredness, sometimes some bowel upset or weight loss. And these were things that needed to be managed sometimes with some other support medications. Another treatment that has been recently approved for relapsed refractory diffuse large B-cell lymphoma is actually quite an interesting treatment in that this is a form of immune therapy. So the drug that was approved was called tafasitamab. It is a kind of monoclonal antibody. So Again, antibody treatment like rituximab. Here, the antibody is targeting the marker on the cell that it's actually the same marker that CAR T-cell therapy targets, called CD19. In this combination treatment, it was combined with a pill medicine called lenalidomide, which has been available for some time now and used for other kinds of B-cell cancers. And in this combination of the tafasitamab and lenalidomide, it was designed to really corral the immune system and target the immune system around the diffuse large B-cell lymphoma. So the trial that got this drug approved, again, was performed in people who had had at least one prior treatment for diffuse large B-cell lymphoma. This trial, the drug is given, tafasitamab is given as an IV treatment, initially quite frequently. So it gets given weekly for 3 months and then gets given every 2 weeks, kind of indefinitely until there's sign of lymphoma growth. And the lenalidomide, which is a pill, gets given for the first year only. In this trial, we saw quite a few people benefit. So about 60% of people actually had shrinkage of their lymphoma, and just over 40% of people actually were able to achieve a complete remission with this treatment. And in some cases, it was a very long period of control that's been going on for more than 3 years in some of the follow-up that we have. Again, focusing on what are some of the side effects that we see with this treatment, which are listed on this side of the slide. The main side effects that were seen were some low white blood cells, red blood cells, and platelets, some bowel symptoms like diarrhea or fatigue, and some risk of infection. Most of these side effects, interestingly, were seen in the first year of treatment and were probably due more to the lenalidomide than the tafasitamab antibody. The final treatment I'll mention that was recently approved for relapsed refractory diffuse large B-cell lymphoma is very similar in that it's the kind of class of drug of the polatuzumab that I talked about at the beginning. It's called an antibody drug conjugate, so an antibody connected to a chemical toxin. This drug has a big name. It's called lancastuximab tesirine. But in this case, the antibody component, again, is targeting the CD19 on the cell surface. This is the same target as CAR T-cell therapy. It's the same target as tafasitamab that we talked about. Here, the chemical toxin is something called a PBD dimer, which again is designed to hurt DNA, but it is a form of targeted treatment. So similar to the polatuzumab that we talked about, it gets stuck on the cell, it gets swallowed up by the cancer cell, and the toxin is released in the cancer cell itself. The trial that got this drug approved by the FDA was performed in patients with relapsed refractory diffuse large B-cell lymphoma that had come back after at least 2 prior treatments. This is an intravenous drug that was given initially every 3 weeks for up to a year, and then was continued after that every 3 months indefinitely until the lymphoma progressed. These are the results that were shown in this initial study. And again, what we saw was fairly good activity, where about half of people actually had their lymphoma shrink and benefit from this treatment, and about a quarter of people actually achieved what we call the complete remission, with their lymphoma being unmeasurable on the treatment. And again, some of this data is still relatively early, but for some people that benefited, it has been continuing now for more than 2 years of time. What were some of the side effects that were seen with this treatment? Well, the main side effects, again, had to do with some low blood cells, mainly low white blood cells, red blood cells, and platelets, and also a temporary increase in some of the liver enzyme blood tests that was generally not of any concern, but was noted in this trial and was generally temporary. So with that, I hope I've impressed that we've got many new options to use in the relapsed refractory setting. Which option we would use really depends on what our goal is. So with stem cell transplant or CAR T-cell therapy, I would say the goal based on the data we have is to try and cure the lymphoma with those potential treatments. For some of the novel therapies, I showed you 4 novel therapies that are available now based on FDA approval. I think it's too early to say whether or not any of those treatments have potential to cure diffuse large B-cell lymphoma. I think it's encouraging that many people have responded to those treatments, that have had their lymphoma shrink away and achieve a complete remission. But for all of those treatments, I would say we need longer follow-up to see whether or not we can say they have the potential to cure lymphoma. But it's certainly leading to really good benefit for many people. And I think we look forward to seeing the longer follow-up, because a lot of this data really has only been developed and emerged within the last few years. I said that none of those treatments have been compared against each other. So which treatment should you use? I would say that, in most cases, doctors are probably having conversations with their patients, talking about the data, talking about the side effects, and which choice might be the next best treatment for any individual person might be different based on who that person is and their underlying health status, keeping in mind some of the side effects that we talked about, and also patient preferences, because as I said, some of them are pill drugs and very convenient. Others might involve going to the clinic fairly frequently to get an IV infusion. And the good news is we now have options, and all of these things can be weighed in an individual person to decide what might be the next treatment to use. I think the future goal would really be to develop blood tests or biomarker tests, as we call them, that tell us more about the individual biology of the lymphoma in an individual person, and link that biology up with the best drug that might work against that biology. I'd say we're not quite there yet, but there is a lot of work going on trying to understand what it is about the lymphoma that does respond so well to some of these unique targeted therapies, so that we can probably use them in a smarter way and pick the right drug for the right person. And I'm hopeful that in the future, we will have those kinds of tests that allow us to use them in a smarter way. I'm just going to finish briefly on a new treatment that is coming very soon that we think might be approved this year for relapsed refractory diffuse large B-cell lymphoma. And because I'm sure that there are other talks in this meeting that are addressing this, I'm just going to briefly mention this. So we're very excited about the new class of drug that we call bispecific antibodies. These are antibodies that are designed to have 2 targets. One target is on the B-cell lymphoma. The other target is on normal T cells. As I said earlier, an important part of the immune system that's designed to fight off lymphoma. And there are many bispecific antibodies in development that have slightly different designs, and they're all showing very encouraging data. I'm just going to mention some of the data from one of these called glofitamab that was recently presented at the American Society of Clinical Oncology meeting in this last year. This was a bispecific antibody tested in people with relapsed refractory diffuse large B-cell lymphoma who had had at least 2 prior lines of treatment. This is given intravenously, and it's given every 3 weeks, initially with a bit of a step-up dosing, so small mini doses weekly in the first cycle, and then every 3 weeks after that for up to a year of treatment. What was very exciting is that this was a novel kind of immune therapy, and these trials are showing great benefit with, in this case, more than half of people having their lymphoma shrink down and benefit, and about 40% of people actually achieving a complete response with their lymphoma no longer measurable. Now, data is still quite early, but we are seeing people have very nice control, even up to more than a year, but we don't have very long follow-up to know how long this benefit can last. But it is something that perhaps can be reused in people, sorry, to get even longer benefit. So this is data that's just emerging. What are the side effects of bispecific antibody therapy? It does come with a bit of a novel side effect, excuse me, called cytokine release syndrome. What we do know is that when the immune system goes into action too quickly, sometimes chemicals can be released by the body's own immune system that can cause some side effects like high blood pressure, low blood pressure, asthma-like symptoms, and sometimes difficulty breathing. And this is something that needs to be monitored for. That's why we have the little mini doses in the first cycle to try and reduce the likelihood of this happening. Although it is a potential side effect of bispecific antibodies, it's something that can be treated with a drug called tocilizumab, and it's generally mild in most people and only occurs generally in the first cycle. So it's a unique side effect that will need to be managed with this treatment, but it's something that is very manageable. Aside from that, it can cause some low blood cells as well and some temporary elevation in the liver tests. So to summarize, and this is a lot of information, but hopefully I've impressed upon you that there are now numerous novel therapies that have shown benefit for relapsed refractory diffuse large B-cell lymphoma and other aggressive B-cell lymphomas. They've now actually made their way into the clinic and are available for use. Many of these options rely on unique mechanisms that are very different from chemotherapy and in many cases targeted. Some of these treatments are what we call immune therapies, and it really has been a very powerful proof of principle of how important the immune system can be and how we can harness the immune system to fight off diffuse large B-cell lymphoma. And I think what's most exciting is that all of these treatments really are improving outcomes in relapsed refractory diffuse large B-cell lymphoma and making a real difference in people.